Psychomotor refers to the relationship between cognitive functions and physical movement. It involves how mental processes influence voluntary motor skills. Here's a breakdown of psychomotor affects and uses. Psychomotor effects. These are the ways psychomotor functions are influenced or altered, especially in clinical or psychological contexts. Psychomotor agitation, restlessness, fidgeting, packing, often seen in anxiety, depression, or mania. Psychomotor retardation, slowed physical and emotional reactions, common in major depressive disorder. Tics and stereotypes, sudden, repetitive movements often seen in Tourette syndrome or autism. Catatonia, a state of unresponsiveness or bizarre posturing, can occur in schizophrenia or mood disorders. Neurological disorders, Parkinson's, Huntington's, or stroke can impair psychomotor coordination. Uses of psychomotor skills. Psychomotor skills are critical in various fields and daily life. Education, learning to write, draw, or use lab instruments, involves psychomotor training. Medicine, surgeons, nurses, and other professionals need refined psychomotor precision. Sports and dance, coordination, timing, and body control are essential psychomotor skills. Driving and operating machinery requires hand-eye coordination, reaction time, and spatial awareness. Occupational therapy helps patients regain or develop fine and gross motor skills after injury or illness. Military police training involves reflexes, shooting, combat maneuvers, all rooted in psychomotor learning. Psychomotor affects in mental health. These are physical manifestations of mental states, often observed during assessments. Psychomotor agitation. What it looks like: packing, tapping fingers, wringing hands, restlessness. Associated with anxiety disorders, mania, severe depression, schizophrenia. Psychomotor retardation. What it looks like: slowed movements, delayed speech, reduced facial expressions. Associated with major depressive disorder, especially melancholic type, catatonia, sometimes schizophrenia. Catatonia. What it looks like: stupor, rigidity, waxy flexibility, echopraxia, mimicking movements, mutism. Associated with schizophrenia, mood disorders, or trauma-related conditions. Tics or involuntary movements. What it looks like: sudden, repetitive, non-rhythmic movements or sounds. Associated with Tourette's, OCD, anxiety. Disorganized or bizarre movements. What it looks like: unusual posture, purposeless movements. Associated with schizophrenia or psychotic episodes. Uses of psychomotor observations in mental health. Diagnosis. Helps clinicians identify disorders like major depression, schizophrenia, bipolar disorder, or neurodevelopmental disorders. Often used in rating scales, e.g., Hamilton Depression Rating Scale includes psychomotor changes. Monitoring progress. Improvement or worsening of psychomotor symptoms can indicate how a patient is responding to treatment. Risk assessment. Severe psychomotor agitation may suggest a risk of harm to self or others. Catatonia might require urgent medical intervention. Treatment planning. May influence whether patient needs inpatient care, medication, e.g., benzodiazepines for catatonia, or specific therapies. In psychiatric evaluations, psychomotor behavior is a crucial observation that provides insight into a patient's mental state, especially during the mental status examination, MSE, one of the core components of the assessment. Psychomotor assessment in the mental status exam, MSE. 1. Appearance and behavior. The clinician notes motor activity as part of the initial impression. Is the patient moving normally? Are they overly restless or unusually still? Are there any involuntary movements or abnormal posturing? 2. Psychomotor activity categories. Normal, smooth, appropriate movements. Agitated, fidgety, packing, hand-wringing, inability to sit still. Retarded, slowed, delayed reactions, sluggish speech or movement. Catatonic, immobile or bizarre postures, mutism, waxy flexibility. Tics or stereotypes, repetitive, purposeless movements. 3. Related observations. Eye contact, too intense or completely absent, can suggest psychosis or anxiety. Gestures may be excessive in mania or lacking in depression. Facial expression, flat affect may align with psychomotor retardation. What psychomotor changes can indicate clinically? Observation, possible indication. Packing, fidgeting, anxiety, agitation, mania. Slowed speech and movement, major depressive disorder, negative symptoms of schizophrenia. Sudden movements or tics, Tourette's, OCD, anxiety. Unusual postures, catatonia, schizophrenia. Freezing or immobility, trauma response, severe depression, catatonia.